Good evening to everyone present here with us today. This is Shriyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned Professor, Dr. Anil Sharma. Sir is MD, DM Cardiology, FAPCS, DSc, FWSIM, FSCAL, FACC, Professor and HOD of Cardiology at Bombay Hospital, Mumbai. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is insight of aggressive lipid management. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
For keeping such an important topic on the eve of World Heart Day, and the theme is use heart for action. Today, in next 30 minutes, we are going to discuss about the lipid lowering and more about the aggressive lipid lowering. The most important thing is the cardiovascular disease is the commonest reason for death. 33% people die from the heart disease, and more so in India, it is about the latest report 28% people die because of atherosclerotic cardiovascular disease. When I say ASCVD, it means coronary artery disease, stroke, that is ischemic stroke TIA, peripheral artery disease, and atheromatous aneurysm of the abdominal aorta. So that is number one killer. And we have more disease as compared to the global incidence and prevalence. And more importantly, India, we have this disease or events a decade earlier than the Western world. There are so many risk factors for ASCVD, particularly acute MI. In the wonderful inter-heart study, which was published in Lancet 2004, Dr. Yusuf Salim showed that lipids are the number one reason or modifiable risk factor for ASCVD. What is lipid? Lipid is one of the major molecules like protein and carbohydrate. So this is triglyceride, cholesterol, phospholipids, are so many. It cannot be dissolved. They cannot be dissolved in the water. So to be carried in the body, it is to be taken by the apolipoprotein. So it is called as lipoprotein. It travels into the body. So lipid plus protein. So there are two ways lipoprotein pathways. One is exogenous, what we eat, fat what we eat, and it is from the liver. It is from the absorb as a chylomicron. Then chylomicron, which consists of triglyceride and cholesterol, goes to the whole body, and there the body takes out the triglyceride. What is triglyceride? It is a glycerol plus 3 fatty acids. So free fatty acids is used as an energy source. The remaining is chylomicron remnant. The other pathway is the endogenous pathway, that is the liver forms this VLDL, that is very low density lipoprotein. Again, it is lipid plus protein. It travels throughout the body, and where again the fatty acids are taken, so less triglyceride, and the remaining is intermediate density lipoprotein or VLDL remnant. Again, it is converted into the LDL. So these are the particles. Any particle which is less than 70 nanometer deposited into the endothelium. Mostly it is like that, all ApoB, but since the LDL remains 48 hours in the blood, the most important thing is LDL. Other ApoB protein particles are also atherogenic. So they get deposited on the walls of the coronary arteries and other vessels, and it causes atherosclerotic cardiovascular disease. There are 3-4 figures, but we need. Lipoprotein is a risk factor. Whether reducing lipoprotein by medicines reduces the event, we do not know. There are so many trials are going on. Triglyceride reduces the size of the LDL, so it makes a small LDL, so that it deposited more aggressive. So LDL is the villain. It is a bad cholesterol which is made more bad or ugly by triglyceride. HDL is a good cholesterol. It takes away the cholesterol from the cells and deposited into the liver. It is a good, but increasing HDL does not reduces the event. So the ultimately the most important thing is LDL. We have to reduce the LDL. So LDL is the causative agent of atherosclerosis, and lowering LDL decreases the event. So lower is the better. How low? And should we reduce everybody? So it depends upon the how much cholesterol we reduce. If we reduce the 1 millimole, that is 39 milligram per deciliter cholesterol, it results in the LDL cholesterol. It results in the 20 to 23% reduction, like coronary event, vascular event. So roughly 40 milligram cholesterol lowering results in roughly 20 percentage reduction in the event in the 5 years. If we treat this for 10 years, it is maybe around 30%. If we give this for 40 years, this is around 55%. So the duration is very important. Other important thing is that apart from the statin, this earlier we thought that LDL reduction by statin is important. Later we came to know whichever way, whichever medicine, whether it is a ezetimibe, which is a bempedoic acid, whether it is a PCSK9 inhibitors or inclisiran, whichever way the LDL is lowered, the event rate is low. So lowering of LDL is important. How low? At birth it is 25 milligram, but any trial, anything lower, even up to 10 or 15, it has not shown any bad result. So anything which is low is good, but as we go down, lowering is very difficult. So 4 point is to be reduced, to be seen that absolute benefit of event reduction depends on drug and doses. Like moderate intensity statin reduces 30% cholesterol. Strong, that is a intensive statin reduces 50%. Ezetimibe and bempedoic reduces 15 to 25%. Then PCSK9 and inclisiran reduces about 50 to 60%. So it depends on the which drug in what dose we are giving, the percentage reduction of LDL cholesterol is there. But it again depends on how much is the absolute level at what you start. Let us say somebody's LDL is 160, we make it half, it becomes 80. Other person's is 80, I make it half, it becomes 40. So it is the amount of the cholesterol which is reduced, it results. So 40 milligram LDL reduction results in the relative risk reduction of 20%. So I have two examples here. Like one patient, LDL cholesterol is baseline is 160. Other important factor is what is the risk factor. Like somebody is diabetic, already a CVD, smoker, HDL is low. Other is a younger fellow, there is not a CVD, just maybe diabetes or maybe some little risk factor. So what is the baseline absolute risk of a CVD, which we calculate for 5 years, for 10 years, maybe for a lifelong. We calculate, there are different formulas. So four things are important. Which drug in what dose, what is basal LDL, what is the risk of the basal risk of the CVD, and what is the duration of drug, as we discussed. So one example, LDL is 160. Let us say the high risk, CV risk is 15%. We give moderate statin, which reduces roughly 25% reduction in the cholesterol. So it reduces 40 milligram, 25% of 160, that is 40 milligram. Relative risk percent. So 20% of 15% is 3% absolute risk reduction. While other side, somebody's LDL is already low, means not very high, 90. It is not very high risk patient, CV risk is 10% only. And we give same dose, but it results in the absolute LDL reduction is 23, which is 25 of 90 milligram. So relative risk reduction is 11%. So 11 into 10 is equal to 1.1%. So same dose medicine, two different person depending on the basal LDL and absolute risk reduction. The absolute risk reduction of the event is 3% versus 1%. So this is, you can see with the chart, same thing. So higher the basal value, more is the benefit. Higher is the basal risk, more is the benefit. Higher the dose or more stronger molecule, more is the benefit, and more the duration, better is the benefit. So what does it mean 10%, 20%, 40%? If we give, let us say somebody has a 10% risk, means if we give medicine or we don't give medicine, if this patient over the 10 year, 10 will have events, let us say maybe MI or maybe peripheral vascular disease or stroke or MI, 90 is nothing is going to happen. But if we give the medicine, instead of 10, if 40% reduction is there, 4% event will be less. So 40% risk reduction in a 10% risk patient over a 10-year this follow up, we will reduce the 4 event. It is not 40 event, it is the 4 events. So now we know how these guidelines treat these patients. Assess the basal risk, see the basal lipid, see the target depending on the risk and what is type. So there are basically 4 groups which benefited by this lipid therapy. 3 are primary prevention, means already do not have a CVD, no blockage, very high cholesterol, mostly it is genetic, maybe more than 190 milligram LDL. Another group is diabetes. Third is high risk score, which I discussed about the ACC 10-year risk we see. Depending on 5%, 7.5%, 20%. If it is more than 20%, definitely we have to give medicine. 7.5 to 20% risk is there as per American Heart Association and American College of Cardiology guidelines, which will start at least moderate statin. 5 to 7.5% depending on other factors like whether is a calcium score is there, or we need to discuss with the patient and treat accordingly. The highest risk is the secondary prevention, means already those have a CVD, as I already told it is CAD, acute coronary syndrome, chronic coronary syndrome, already angioplasty, post bypass surgery, or ischemic stroke or TIA, or peripheral artery disease including atherosclerotic aortic aneurysm. So this patient benefit, this already I mentioned about the depending on the which dose, how much LDL reduction is there. Like moderate intensity, 30% LDL reduction, high intensity, 50% reduction, high intensity plus agitamib is around 15%, alone agitamib it is 25%. PCSK9 60%, PCSK plus statin 75%, PCSK plus statin plus agitamib 85%, bempedoic is 15 to 25%, agitamib plus bempedoic 35%. So it depends on different combination. These are the percentage expected. So this LDL reduction will reduce in the event risk. So this is the guideline which I already mentioned, that 5%, 5 to 7.5%, 7.5 to 20%. This is primary prevention. So other is about the secondary prevention, that everybody should be on high statin. Those who are very high risk. What is the concept of the very high risk? We'll see, has to be more aggressive. So this target they keep it around 70. The European guideline, this was the 2018 ASCC guideline, kept in the target of the threshold was the 70 LDL threshold. 2019 is ESC guidelines, European guidelines. They say no, it has to be more aggressive. Plus they say 50% reduction. You can see the graph here that up to 70 the reduction is significant. Then graph become the flat. Still benefit is there, but it becomes more difficult. So try to reduce it up to the 55. So how India is different? Now Indians are more riskier than the Western world because we have more triglyceride which make the LDL more smaller. We have high triglyceride. We have low HDL, so good cholesterol is less. So we are, because of our lifestyle, cooking patterns and our genes and our this triglyceride and HDL, we are higher risk. The statin problem is there. All patients do not respond very well, so we call it hypo responders. All patient does not take medicine regularly. There is a not good adherence, and in spite of all this, some patients have some problems. 7 to 19% have a intolerance, that is a muscle problem, statin associated muscle symptoms. In spite of this statin and all lipid chlorine, there is significant residual lesions are there. There may be other reasons, like it is a multifactorial. Apart from the lipid, there may be diabetes, there is a blood pressure, there is a low HDL, smokers, lack of sleep. There are so many obesity, there are so many risk factors. This results in the residual risk. So there are different guidelines. The Indian guidelines are more stricter. We have two Indian guidelines, CSI 2023, and then Lipid Association of India is the more ever stringent than the Indian guidelines. And one thing is more important, that apart from the LDL goals, now we have non-HDL goals. So we have more stronger guidelines. Why? Because we are, as I said, high triglyceride and low HDL. High triglyceride result in the small than LDL. And other thing is dietary pattern. We keep more carbohydrate, low polyunsaturated fatty acids, and we use partially hydrogenated fats, reheated oils we use, and high heating cooking is there. We develop heart diseases at the younger ages, and our diseases are increasing. So we are at more risk. that is the some this prevalences is there. Earlier we used to say that LDL is not very high, but we found now that LDL also is high. Even 50% persons population have more than 100 LDL, and around 30% is more than 130, and 70% has more than 70 LDL. So if it is a high risk patient, anything who has a diabetes or any this thing, so 70% have more than 70 LDL, and even in spite of the LDL, even one third patient achieve the target LDL. So we need something else. So this was the 2019 guidelines. Add the statin if it cannot be controlled to the 55 as per their guideline, agitimib, then then add the PCSK9 inhibitors. Now this is changed in the 2020 from the high intensity statin monotherapy to the hill, that is high intensity lipid lowering, whichever way, because we know that lipid has a lot of problems. So ESA 2022 annual meet focus that if this is high risk, right from the beginning go for the statin and agitim. If it is a very extreme high risk patient, right from the beginning go with the statin, agitimib and PCSK9, which is injectable twice a month. It is injectable this thing, but now bempedoic acid also has come. So what is the position paper in 2023 by International Lipid Expert Panel? So what it says, what is the risk factor and what is the basal LDL? So if basal LDL is from baseline LDL is 110 to 160, we need 65% reduction. So start right from the beginning, statin and agitimib. If it cannot reach to the 55, still more, add more medications. Bempedoic acid, even it cannot be controlled, then add the PCSK9 inhibitor or inclisiran. If LDL is more than 160, from right from the beginning, give the all three oral medication, statin, bempedoic acid and agitimib, which can result in the 75% reduction. Still, if it does not reaches less than 55, add the PCSK9 by this PCSK9 inhibitor or maybe inclisiran. Those with the very high risk patients, those who cannot tolerate statin, if partial tolerance, you can add the other medications. If it is a completely intolerant, add agitimib plus bempedoic acid and then add injection if required. So targets are clear. What is the CSI says, Cardiological Society of India, the targets are 55 like ESC, and if it is a recurrent event, then make it 40. Without SCVD, 70. So if you want to remember three figure, 70, 55 for 70 for without ACVD. For secondary prevention, ACVD 55 if it is a recurrent event, or ACVD with some more risk factors like diabetes, particularly target organ damage or long-standing diabetes, multiple risk factor, make it 40, even less than 30, and even Lipid Association in India says that it can be reached. There is no harm in reducing up to 15. Though with increasing, with as we go lower, it is very difficult to lower this thing. So benefit is more, but below 55, it is difficult to achieve, and the benefit is little less if you go lower. This is what CSI says. If it is a ACS, start right from the beginning, is high dose statin plus agitimib. After 4 weeks, add bempedoic acid. Another after 3 months, see the LDL is less than 55, and again, as I said, non-HDL less than 85, then go for the injectables. Well, CCS, it is little different, that instead of going statin plus agitimib, start with the statin, wait for 4 weeks, go for agitimib, add another 4 weeks, add bempedoic acid, then another 4 weeks, then go for the other medication. So step by step can be there if this patient is stable. If it is unstable, you should go very fast. So this is about the triglyceride. If it is more than 500, definitely to prevent pancreatitis, we need some fibrates, omega-3 fatty acids and seraglitazone. If it is 150 to 500, in spite of the lifestyle medication, with those with the high risk factors, we may add EPA can be given. So what is now LI, that is a Lipid Association of India. There are so many groups which I already discussed, but they say in the extreme risk group, there is a recurrent event with multiple risk factors with ACVD, its target should be less than 30. So in diabetic patient without ACVD, 70, with target organ damage, 50. Diabetes plus ACVD, target is 50. Those with the target organ damage or multiple risk factor, the target is 30. So diabetic, it becomes more aggressive. So these are the, as I said, Six medicines are there: statin in the moderate intensity and high intensity, ezetimibe. So where that does it work? And bile acid secrets in rarely for pregnancy. It was statins were contraindications during pregnancy, but it is removed by ACC. But only should be given if there is a very high risk patient. Otherwise, in pregnancy, the preferred dose is bile acid secretrant and EPA. So other things like you see, ezetimibe work at the intestine, while statin work at the HMG enzyme reductase inhibitor, and this bempedoic acid work little earlier, higher up. It is ATP citrate lyase inhibitor, and there are two medications which were working on the PCSK9. What is PCSK9? PCSK9, you can say that it stop the recycling of the LDL receptor. So if LDL receptor is destroyed, it cannot take the LDL out of the vessel into the liver. So more LDL is there. So PCSK9 inhibitor, what it does, it is an antibody which it does not allow PCSK to act on the PCSK receptor. So LDL is recycled, receptor is recycled, so it can remove more LDL. So it reduces about 50 to 60%. And what about the inclisiran, that is a small interfering RNA? It does not allow PCSK9 receptor to be formed by working as a various genetically in the various forms. So atorvastatin and rosuvastatin, you can see like these are the very strong statins. At the lowest dose they work as a 32% reduction, and highest is around 45 to 50% reduction is there. So higher is better, definitely. TNT, it was 10%, 10 milligram atorvastatin versus 80 milligram was compared, and there was significant difference in the higher doses. But there are certain issues with the statins. They are underutilized. You can see 30 to 50% patients are not on statin. Why? Because there is a poor adherence. Like 26% non-adherent do not take statin, stop. 31% take irregularly. Only 43% take medicines regularly. Why? Again, there are certain issues, because 50% you can see they are not hyporesponders. The response is not proper. So that's why they added the 50% reduction in the LDL from the baseline to make sure that some LDL is reduced. Maybe patient maybe is taking regular medicine, but they are hyporesponder. So other thing is does not reach to the target goal. Maybe hyporesponder, maybe non-adherence, or maybe that in spite of this, the drug is not enough. So we may require more powerful medicine. There are so many side effects are there which we need to see, that predisposing factor for statin associated symptoms, like what are the patient related factors like elderly, female, lean and thin, those with the comorbid conditions like HIV, liver, kidney and thyroid diseases, pre-existing myopathy, unexplained cramps, Asian people, excess alcoholic intake, excessive physical activity, major surgery or perioperative period, trauma, and family history of myopathy. These are patient related factors. Others are treatment related factors like high dose statin therapy. Some people are causes more pain with the dose related. Concomitant dose, other anti-lipid lowering medicines, earlier those who are using can use to the more myalgias. Fibrates, amiodarone, verapamil, macrolide antibiotics, cyclosporine, antifungals, HIV protease inhibitors, nafazodone, to just mention few names. So that is very, very important. So these drugs, when you are giving statin, particularly in high dose, you should be take care that you should avoid using with these drugs. So for you say how when we treat the 10,000 patient with the statin, 5 myopathy, 10 strokes, 50 to 100 diabetes, but 500 to 1000 MACE are averted. So there is a more benefit with the less risk. Statin intolerance is found in 5 to 17% patients. In spite of that, there are still 70% there is a residual risk. There are so many other features, as I said, diabetes, obesity, inflammation, lipoprotein A, triglyceride and HDL, and blood pressure. So now quick thing about the drugs like improve it. It is about ezetimibe. It works in the intestine. It reduces the absorption of the cholesterol. So there are with the improve it trial, it was carried about 6 to 7 years. And in simvastatin group, there was 34% event. And when ezetimibe was added, the 2% absolute risk reduction was there. So it's significant. More importantly, the more benefit was found in those with the risk factor. They make the 9 factors, like those has congestive heart failure, hypertensive, age more than 75, diabetes, prior stroke, prior bypass surgery, peripheral artery disease, EGFR less than 60, CKD, smoking. Those who has 0 or 1 risk factor, there was very little difference. Those who have 2 to 3 two factors, there is benefit was 2%. But those who have more than 3 factors, the absolute risk reduction was 6%. So higher the high risk, more is the benefit of adding the adjunctive. Another trial, this is about the rosuvastatin 20 milligram versus rosuvastatin 10 plus adjunctive. So it improved, so less onset of diabetes, and there was less discontinuation, less side effect in the adjunctive group. So combination is better. Another molecule recently this is approved is a bempedoic acid. It works little higher than statin. The advantage is it is activated in the liver only, so chances of myalgia are very less. The only thing we have to be careful that it increases uric acid, so it can cause gout, and rarely it can cause tendon rupture, particularly elderly, those who are on fluoroquinolones and those who are on the steroids. So these group we have to be very careful. This is about the clear outcome trial which showed the benefit event reduction of that benefit of the this agitamib plus, and then bempedoic acid plus agitamib combination reduces around 36%. It does not reduces the LDL 36%. It reduces the HSCRP, so it is anti-inflammatory. This is again a very important thing for stabilizing the plaque. So this is about the, you can see one side is the antibody, that is a about the PCSK9 inhibitor. It inhibits circulating PCSK9 from binding to LDL receptor on the hepatocyte, while the siRNA, that is inclisiran, it inhibits the translation of PCSK9 messenger RNA in the liver, leading to reduced PCSK9 synthesis. So more LDL receptors, more LDL remover, less atherosclerosis. This is about the PCSK9 inhibitor. This is the two trials. One is about the two molecules, evolocumab and alirocumab, both showed the benefit. This is about the Orion trials are there about the inclisiran, which showed that around more than 50% reduction in the LDL. Now trials are there to show that whether events will be reduction will be there or not. Next couple of years we'll come to know how much is the CVOT, what we call cardiovascular outcome trial, are on the way. So this is the, I think, 2 injection a year, and then there is a big reduction on the statins are on the way. So we have reached to the, from the 4S trial in the 90s, which showed the 35% reduction with around 30% relative risk reduction, to now that lower the better, very extremely about this two injectables are there. But one more important thing is adherence is very important. So that is to be important. So just to conclude, ASCVD is killer number 1. Lipid is risk number 1. Apart from the lipid, we need to modify lifestyle and control the other factors like diabetes, hypertension, obesity, smoking, tobacco, stress, and sleep. LDL targets are as per the, depending on whether normal person it is less than 100, 0 to 1 risk it is 70, is ASCVT is 55, and up to the even 30, even up to 15 as recommended by Lipid Association of India, depending on the risk. So if you want to remember two figure, remember 70 for ASCVD by ACC, and 55 by CSI and ESI. And then if it is a recurrent event, diabetes with target organ damage, it is more riskier, and even it is recommended, the lowest recommendation is by Lipid Association of India, up to 15 can be reduced. So lower is the better, but below 50 there is a law of diminishing returns. The returns are not so. So any event, and there is particular event, it is try to reduce is less than 50. And then non-HDL targets, suppose the LDL targets is 70. So what is plus 30? It should be less than 100. If the target is 55 LDL, the non-HDL should be less than 85. In pregnancy, again, as I discussed, be careful about the statins, and most important thing is adherence. Thank you very much, and happy World Heart Day. Namaskar.
Thank you so much, sir, for your wonderful presentation. So we do have some question if you like to take that up. Hello. So, am I audible to you? Hello, sir. Uh, so, am I audible to you now?
She lost the connection, I think. One minute.
Hello.
Hello, madam. Any questions?
Yes, sir. We do. Can you hear us?
Yes, yes. I can hear you.
Yes, sir. So,
Yes.
sir, we do have some question.
Yes.
So, sir, the first question from our audience is,
Yeah.
how should lipid management strategies be personalized for patient with a history of statin intolerance or adverse effects?
Yeah, the statin I already mentioned, the risk factor I already mentioned. The most common is myalgia. So if it is a common myalgia, mostly patient tolerate. After some time they stop mentioning. But there, if you want to know about the lipid tolerance, we have to stop the medication and wait for 2 to 4 weeks and restart the different statin. If it still symptoms reappears, then it is purely because of statin. Then we should avoid the statin. So there are at the extreme there may be rhabdomyolysis there, but that is a rare things. But commonly it is the myalgia. It can affect the liver. Rarely it can cause diabetes. As I mentioned, if it is the 10,000 patient, there may 5 may develop diabetes. But those which is study has shown that diabetes develops only in those who have already metabolic syndrome or something is a borderline diabetes. So they precipitate or they increases the diabetes pathway. Those who are not going to develop diabetes in the future, they do not develop diabetes. These are the postulates. So depending on the risk factors, if ASCVD is there, in India we keep it, the risk factor is 55. If it is a diabetes plain, 70. If it is with the risk factors, then it is a, so 70 and 50 in the diabetes, and ASCVD 55 and lower depending on the risk factor. So diabetes, the three things are important. One is the target organ damage. What is the target organ damage? Brain, eyes, heart, kidney. So whether there is a retinopathy there or not, nephropathy is there or not, whether the heart is affected or not. So target organ damage. Prolong means long duration, means more than 20 years duration diabetes. And third thing is diabetes with other risk factors. That is very important thing is there. So then you individualize. So everybody, LDL has to be, any patient, it has to be less than 170 in India. If it is ACVD, it should be less than 55. If it is a recurrent event or plus diabetes, then it has to be 40, 30 depending on the recurrence and how many risk factors are there. Because these are very complex actually. So there are 4 or 5 guidelines: American guidelines, European guidelines, Canada guidelines, India we have 2 guidelines. So just to make it simple, 70, 50, 30.
Thank you, sir. The next question is, what is the role of aggressive lipid lowering in secondary prevention of cardiovascular events?
I think it is already everything I have mentioned about the this is thing, that reduction is there. The lipid is number one as per the inter-heart trial. The Salim Yusuf published in the Lancet in 2004 that it is the number one risk factor, modifiable risk factors. So lipids are very important thing. So it is, LDL is the most important. It remain in blood for 48 hours. Next important things are VLDL remnant or IDL, because anything which contain ApoB, like we are moving from LDL to non-HDL, that is a 1/5 of triglyceride, and the next thing which is going to come is the ApoB, because ApoB, all the molecules except the HDL contain ApoB. So now the latest concept is just measure the ApoB, but it is not available right now because we have more trial with the LDL. So LDL is the most proven in India because triglycerides are higher, which make the LDL small, more ugly. So we keep it a non-HDL target, that is a 30 millimeter 30 mg more than LDL. So LDL target is 55, less than 55. Non-HDL is less than 85. So depending on the risk, then we keep it more stringent.
So there is one last question. How often should lipid level be monitored in patient on aggressive lipid lowering regimens, and what factors should prompt therapy adjustments?
So every 3 to 6 months we should check the lipid profile. But again, it again depends what kind of person is there. If it's a young person, who underwent the plasty and there are no risk factors. Once you have lowered down the LDL, then you can check it once a year only. So again, there is a guideline normally says 3 to 6 months initially. Once it's stabilized, 6 to 12 months you should do it. But it depends on the what kind of person it is. Higher the risk, more strict the target, and higher the risk is there, more regular checkup is required. But starting point as per the CSI is 18 years. We should start LDL, and every 5 year as per the American guideline 20 year at the age we should check, and every 5 year it should be checked if it is normal. If it is abnormal, then more frequently it should be checked.
Thank you so much, sir, for answering all our questions.
Lipoprotein A should be checked once only in the lifetime.
Sorry, sir, you were saying something. Please continue.
Lipoprotein A should be checked once only. Their trials are going on, like PCSK9 reduce this lipoprotein A. By reducing lipoprotein A, whether it reduces the event, we do not know. Like there were medicines which improved the HDL, increased the HDL, but it did not resulted in the event reduction. So they say it is a risk marker, not risk factor. If you modify, it is not going to benefit. Same thing is about the triglyceride. Fibrate did not reduce the event. Fibrate reduced the triglyceride but did not reduce the event. Though say fibrates are not of much use. Now EPA has shown, but still there are some theories are there about the triglyceride, whether EPA reduced it or not, what was the placebo which was used in that trial. So there are so many if and buts. But for lipoprotein A, some two trials are going on. One will be public in the 2026. Another results will be out in 2027. We'll come to know. But right now the guidelines is once you should check lipoprotein A, it just tell about the risk marker. Then you have to be more aggressive. HDL is a risk marker. Lower the HDL. The only thing we should do is about the diet and exercise. Triglyceride is again a risk marker as well as risk factor, but not like LDL. So LDL targets, and to involve the triglyceride as a risk factor, there is a non-HDL, means it includes triglyceride, it includes LDL, VLDL remnants, IDL, so many things. So FOB is the culprit. So we are moving from LDL to non-HDL, that is LDL plus triglyceride, and ultimately we are moving towards the FOB.
Thank you, sir. We are about to conclude our session. So before concluding, sir, any last remark from you or any take-home message?
Take-home message is life is precious. ACVT is a killer number one. Lipid is killer number one. Lifestyle is number one. I would say Panch Mantra. Keep your mind cool. No aggression. Take 6 hours sleep. No tobacco, smoking, alcohol. Do the breathing exercise 30 minutes. Do regular exercise 30 minutes, maybe brisk walking, running, jogging, swimming, playing, whatever. And take care of the diet. That is the fifth one. In diet, avoid the junk food, oily things, sweet things, mutton, and take a lot of vegetables, salad, fruits, and nuts and seeds. But fruit, you should be very careful if you are diabetic. So take the opinion of the diabetologist and your dietitian. Thank you.
Thank you so much, sir, for joining us today. With your permission, I would like to conclude today's session. Thank you so much.